Hi everyone, thanks for joining. We're going to get started now. Today we have 30 minutes, one question, one follow-up. Dr. Yaffe and Dr. Huyer are here today, so I'll turn it over to them for some brief remarks.
Thank you very much. Good afternoon, everyone. I'm pleased to be joined by Dr. Huyer, who's Ontario's Chief Coroner, coordinator of the Provincial outbreak response, and a member of our COVID vaccine distribution task force. I will invite him to make some comments once I have provided my update. So since our last update, which is on Monday, Ontario has reported an additional 7,200 daily new cases of COVID-19, and another 181 people have unfortunately lost their lives. We continue to see elevated numbers of people in hospital. At this present time, we have about 1,533 people in hospital with COVID-19 and 388 in the ICU. Although we have observed a slight decline in the last few days. Overall, recent provincial data is showing some improvement. Our provincial case rate has shown a decline for the first time since mid-November, but it still remains high at 145.4 cases per 100,000 people. Our average percent positivity on tests has also gone down somewhat to 5.3% from 6.3% a week before. The reproductive, or R effective number for the province, is currently at 0.87, which is encouraging because it is under 1. Overall, the case rates in most of our public health regions are also improving. 26 of our 34 health units have experienced decreasing rates, with the remaining health units' rates are stable or increasing. However, the case rates in many of our regions do remain high. It's unclear if the reducing or decreasing rates represent a trend. Another week or two of data will be required to assess the trajectory. We are still officially reporting a total of 15 cases that have been identified of the UK variant, or B117, in Ontario. But we do certainly expect to see more as our laboratories test for this and for other variants. And as was announced yesterday by Dr. Charles Gardner, Medical Officer of Health for Simcoe Muskoka District Health Unit, laboratory testing has identified a COVID-19 mutation in 6 specimens from a long-term care home in Barrie, which is experiencing a significant outbreak. The testing for the variant strain is a 2-part test. So at this time, we know that there's a very high probability that the mutation identified is a variant strain of concern. The whole genome sequencing to identify the mutation in detail is being done, and we expect results in the next 3 to 4 days. As Dr. Gardner said, the impact of this outbreak on the facility has been tragic. And these interim results identify the mutation are very, very concerning. We are working together as hard as we can to contain the spread of that virus and protect the residents and staff. As noted last week, our colleagues at Public Health Ontario are now reporting regularly on the number of adverse events following COVID immunization. Of the vaccines administered in Ontario between December 13th and January 16th, which is a total of 200,097 doses, there have been 43 reports of adverse events. Of those, none were considered serious, none required going to the hospital, the most commonly reported event, in fact, in about half of the cases, was an allergic skin reaction. So I do recognize that the province-wide shutdown and their continued closure of schools for many are not easy. But these actions are necessary, and we must all continue to follow the basic public health measures that are in place, including the stay-at-home order, including in order to get a transmission of COVID-19 under control. We're seeing some improvement, but we do need to see more data to determine if some of those decreasing rates are real trends. I'm going to now ask Dr. Huyer to make some comments before turning it over to the media for questions. Thank you.
Good afternoon, everybody. It's great to be here with Dr. Yaffe, and as you know, I listen to Dr. Williams and Dr. Yaffe when they speak, and I hear certain things that I know I reiterate and repeat, but I think some really important things and some sad things. I look back at Dr. Yaffe talked about the number of deaths over the past week. I look back at yesterday's numbers, and there was 89 people. Today, 43 were reported. Terrible. It's a terrible thing. And again, as both we've talked many times before, we continue to share our condolences with those families and people who have suffered losses. The numbers are going down. We're hearing that from Dr. Yaffe. I heard her say improving. I heard her saying staying stable. I heard her saying things are looking a little bit better. Well, hard work is being done by many. People need to stay home. People are working from home. People who have to work are taking additional steps to protect themselves as they go into those workplaces. This is very tough, and it's tough for everybody. And recognize that that there are people at home who are by themselves at many points of the day, and so everybody does suffer from this. And it speaks to, with the improving and hopefully continue to improve numbers, the outcome of such hard work and such terrible challenging situations that we have. Just going to turn a little bit to the outbreaks for a minute and recognize that, again, we've seen some potential flattening of the numbers, with the 7-day number yesterday being 769 and the 30-day number being 1,290. And I think back to when we started having these meetings around outbreaks in August, and that number it wasn't even that, the 7-day number wasn't even that high for a 30-day count. And this is a tremendous number still, a large number. And we are still seeing at least 50, sometimes 50 to 60% of those outbreaks being reported in vulnerable settings: long-term care homes, retirement homes, hospitals, congregate care settings, those where people are in vulnerable settings, group homes, all sorts of challenging locations. The next most common is workplaces, and then it follows through with other settings that are present. We see it in a lot of, as I said earlier, a lot of hospitals, and that again impacts the hospital capacity to be able to provide care, because those areas will be limited for people being admitted to the hospital. So with those numbers and the good, hopefully stabilization, but yet the continued tragedy and continued large numbers, we continue to work together in the best way we can, and we'll open up for questions after this.
We'll go to the phone lines. Just a reminder, one question, one follow-up. Over to the first question, please.
First question comes from Ashley Legasic at News Talk 1010. Please go ahead.
Hi there. I hope you can all hear me okay. Thank you, doctors, for taking my question. We spoke with the Ontario Medical Association today. They say only 100,000 rapid tests out of the 3.5 million that Ontario has have actually been deployed. Why haven't we seen a greater rollout of these tests, and what is standing in the way?
I will start. I'm not sure if Dr. Huyer may want to add. There's been a lot of work done about evaluating the rapid tests, and there are different kinds of them, and what is their ability to identify a case, not to have false negatives or to have false positives, because those have serious consequences. So certainly, I know there was a big pilot done in long-term care, and it found that testing asymptomatic workers actually came out with very good results. Those who tested positive on the rapid test were confirmed as positive through the PCR. Those who were negative were negative. So there is a plan to implement rapid testing to screen workers in long-term care frequently, I believe 2 to 3 times a week. Very soon that will be implemented. I know we're also looking at the potential implementation of rapid testing in school settings and in workplaces. So it has been used in some workplaces already, but one has to keep in mind the limitations of the test. And the gold standard really still is the PCR test, but of course that takes time, and the turnaround time can have negative consequences for management. I don't know if Dr. Huyer would like to add.
Yes, thanks, Dr. Yaffe. So looking at the rapid tests, which is an antigen-based test, so it looks for the antigen as opposed to diagnosing the test through PCR, which is the laboratory confirmatory test. It's how is this test best used? And Dr. Yaffe said this is to look for surveillance, to try and do testing on a regular basis within a certain population that isn't thought to be in an outbreak. So it's not to diagnose, but it will find the disease, but not to be the gold standard for the diagnosis. If it finds a positive in the rapid test, then it'll be confirmed through the PCR. So it's not the kind of testing that would be done in outbreaks or where there is infections. It's to be done to do surveillance or to evaluate for the potential for somebody having a positive test within a setting or a population that is more typically asymptomatic. So as Dr. Yaffe talked about the long-term care home staff, it is being used in a number of long-term care homes, and there's many more long-term care homes that are coming on in the next little while, as I understand it. As Dr. Yaffe said, there is also work going into schools as well as other businesses. One of the challenges that started early on when the rapid tests were provided, it still required a nasopharyngeal swab. So that is something that is hard. Any of you who may have experienced that, it's not an easy procedure. It's an important procedure, and it needs to be done. But having that done twice a week or 3 times a week is a very challenging thing to occur because it's uncomfortable. And so it needed to be done by somebody besides self-administered. And so that in of itself was challenging to be able to develop the plan for rolling this out in a broad way. That's been dealt with, and now testing can be done through the throat and nose together. Observation, and requires people who have expertise to be able to monitor the results and ensure that those tests, when they're positive, are reported and there's proper follow-up that's in place. So there are some complexities to it. That doesn't mean it's not happening. It is moving out, and it is going to long-term care homes, and then that will move the PCR testing that's being done regularly in long-term care home staff to have greater availability for within the laboratory capacity to diagnose illness when may be present in those who are symptomatic or felt to be infected by COVID.
Follow-up?
Thank you both very much for that. Quebec is revisiting, or it may be revisiting its vaccination plan after new data from Israel suggested the first dose of the Pfizer vaccine may only be 33% effective without a booster. Will Ontario revisit its vaccination strategy after this came to light?
So I'll start, and then I think Dr. Yaffe will add some of her greater knowledge than me in vaccines. We have been focused in the long-term care home residents and higher risk retirement homes to recognize those residents are typically older, with an average age in the 80s. And given that, and given the potential that immune response may be not as strong in an older person compared to a younger person, not that we know that with this particular vaccine, but learning from previous vaccines, we have been maintaining in that population the same dose interval that was recommended or was approved by Health Canada and being provided by Pfizer. So that has been something that we've been well aware of and been thinking about. The Israeli information is brand new, and I haven't seen anything scientific yet about it. I've heard media reports, which we have listened to, and we are actively speaking about when we think about any impact on dose intervals.
Yes, just in follow-up, my understanding from reading about the Israeli experience was the 33% effectiveness was after the first dose in people over 60 years of age. Although, again, I haven't seen the actual study or the data. And in fact, I know with Dr. Tam at the federal level, we're trying to arrange a call with the Israeli officials so that we can get better data. However, of course, hearing 33% is concerning. It's not great, but it's at least it's working to some extent. We have been following as much as possible the product monograph from the clinical trials that the vaccine should be given within 21 to 27 days. However, the National Advisory Committee on Immunization, NACI, and the WHO have both said that if the circumstances are such that you need to increase the interval, you can. It is acceptable to go up to 42 days, preferably up to 42 days. And so at this point, if the vaccine supply continues to be an issue, for people who are not older, people who are in the younger age groups, but in the priority groups, we may have to extend the interval up to 42 days. But again, that is not the optimal. We would like to do it within the drug monograph, and we'll have to see what we learn from Israel's experience and also see what happens with the vaccine supply.
Next question.
Next question comes from Colin DeMello at CTV News. Please go ahead.
Hi, good afternoon, doctors. Dr. Yaffe, on Monday you had said that there is evidence of community spread of the new variant of the virus. Clearly it's popping up in a variety of locations now. I'm just wondering, during the first wave, there seemed to be community spread long before there was real evidence of it. How long do we believe that there's actually been community spread of this new variant in the province, and how widespread is it?
I don't think we know. The testing for the variant has been developed by the lab, the Public Health Ontario lab, some research labs, the national lab. And I know that I believe the Provincial lab has just done what we call a point prevalence study, looking at all the samples that were taken that were positive on a certain day, and testing them all to see if there's any evidence of a variant of concern in there. And those results will hopefully be available in a few weeks. So that'll give us a better idea of how prevalent it is across the province. And right now, the routine testing is being done. Anybody who has a history of travel or contact with a person with a history of travel, any evidence where there's a super spreading event. So that's why we tested the specimens from the long-term care home in Barrie, because the spread was so quick and so serious that there was a concern there that it might be a mutant spread, and which it is. Also looking at any cases of reinfection or potential vaccine failure. So there are certain groups, and it's also done on random samples. So we'll get a better idea from the prevalence study. And the fact that we have found now, of our 15 cases that we know about, I believe in 4 of them we have not been able to identify any connection with travel. So that's what's telling us that it is in the community.
Follow-up?
Appreciate it. There are also reports that a man who traveled from Western Africa died of COVID-19 not long after arriving in Canada. I'm wondering if we have any additional information about that case and whether the African variant of the virus has been detected in Ontario as well.
So, Colin, it's Dirk Huyer. I'm not aware, as the Office of the Chief Coroner, that we had involvement in that particular case, so I apologize that I don't have an answer for you. I don't know, Dr. Yaffe, if you'd heard anything about that.
No, actually, that's the first I've heard of that. So we'll see what we can find out, but no, I'm not aware of anything about that.
Question?
Next question comes from Anthony Fury at Toronto Sun. Please go ahead.
Hi there, Dr. Yaffe. Today's new Sick Kids report warns of what they call the significant harms of school closures and says that additional delays to reopenings will only further add to those harms. So, given this, how do you justify to all those parents who do want their kids back at school this continual pushing back of reopenings, especially since Dr. Williams recently said there's been hardly any in-class transmission at all in the province?
Yes. We definitely want kids to be in school. That is the best thing for them for a whole lot of reasons, including but not limited to, obviously, their learning, but also their mental well-being, their social well-being, and their physical health. So it's been a challenging situation. we found that the rate of positivity in kids had gone up quite a lot just around the holiday period and after the holiday period. And there was so much transmission that we felt at that point, going into a lockdown, it would be safer to keep them at home in the south part of the province. As we assess the indicators regularly, we actually have just informed 7 public health units that as of Monday, their schools will be able to go back to in-person learning. And we're watching all the others as well very carefully. But what we need to remember is that we do have a lot of layers of protection in the schools. But if the community infection rate is high, that's where it comes into the schools. And it becomes unwieldy for the school, for the health unit, and for the kids and their families to have kids being sent home and whole cohorts being sent home frequently. So it's not a simple situation, and we're continuing to monitor very carefully and put in more measures as appropriate.
One of the challenges with a high number of cases in the community is that teachers may be infected within the community, not specifically in the school, and then the teachers won't be available to, unfortunately, attend in the school, or if there is any intersection between those. So there's a number of competing challenges that occur within the school. But I wholeheartedly agree with Dr. Yaffe that kids returning to school is really the goal for so many reasons, but have to balance all of that with all of the number of cases and the challenges that can occur when virus is brought into the school.
Follow-up?
The kids was trying to sort of list those various harms, but have you performed an actual cost-benefit analysis on the broader implications of the current lockdown measures?
I have not personally done that, but I mean, we're obviously very aware of all, there are significant harms that can result from every measure and significant benefits. And it's always a question of looking at the risk and trying to minimize the risk and maximize the benefits.
Next question.
John McGrath at TDO. Please go ahead.
Good afternoon. I have a question a bit about the interval of some of the shots. As of yesterday, the 20th, 40,000 people have received their second dose, but 40,000 people had only received their first dose by the 3rd. We are not yet at 21 days past the 3rd of January. It's not a huge difference, but I am curious if some people are getting their second shots sooner than the 21 days, or whether this is maybe just a data issue.
No, I'm not aware of anybody receiving their second shot prior to the 21 days. For Pfizer, BioNTech, it is 21 days, and for Moderna, it is 28 days. And at this point, I'm not aware of anybody receiving anybody earlier. We've been very clear, Dr. Williams, Dr. Yaffe, in the communication that 21 days is the minimum period of time between doses.
Follow-up?
I'm wondering if you can say anything more about what the government is considering in terms of rapid testing in schools, whether this would be, if a child started showing symptoms during the school day. Obviously, if they're symptomatic, they shouldn't be sent to school in the first place, but a kid could start having sniffles in the middle of the day, or is this going to be for teachers, or anything you could tell us in more detail about what the government is considering there?
Well, we are working closely, obviously, with the Ministry of Education and with other partners, to figure out what the best way to do this is. One of the things that we did pilot back in November was called Asymptomatic Surveillance, which really was, I would call it case finding, which was if we had an outbreak or a case, evidence of a case or transmission in a school setting, in the health units that had a lot of transmission, Toronto, York, Peel, and Windsor, I believe, at that time. Perhaps Windsor wasn't included. Anyway, what we did was we worked with them to test the kids in the cohorts that were sent home, and their families, and the staff, depending, if they were agreeable to being tested. So that was trying to find out, are we missing cases? Are there more cases? Generally speaking, I think the finding was like around 2% positive, which is very low, which is good. So I think that we're looking at maybe continuing to do that when we open schools. That would be working with the local health department and saying, you know, if you have a case or you have an evidence of an outbreak with transmission, this is something you should be doing to look for other cases. In terms of using the rapid test, that's something we're looking at right as well actively now, which is, do we use it only on symptomatic? We try to only use it on asymptomatic kids or asymptomatic people. If we were to use it on symptomatic people, then we have to look at the qualities of the test and what it would mean to get a positive or a negative. So those are all discussions that are happening right now.
Last question.
Last question comes from Rob Ferguson at the Toronto Star. Please go ahead.
Hey, sorry, my fingers are slow on the phone. I'm wondering, in terms of this Barrie outbreak, do you have any reason to believe that there may be more cases of the UK variant in the Barrie area outside that nursing home? And are you testing wider in Barrie for that?
Well, I just got off a call actually with the health unit there and Public Health Ontario and Public Health Agency of Canada talking about that outbreak and what we should be doing and what testing's happening and should be happening. So at this point, as I said earlier, we know there's a mutation in there, the 501 mutation, that's associated with increased transmissibility, about 56% more transmissible. We don't know which mutant it is or which variant of concern. Is it the UK? Is it the Brazil? Is it the South African, or is it another one? So we're waiting for those results, which we're expecting to get in a few days. In the meantime, we're not waiting, and they're doing more testing. They're going to step up even more on infection prevention and control. And they're looking to offer vaccination to there's a retirement home right next door. So we'll have to see where this goes in terms of trying to figure out what's the source of this infection, and if we can. And is there any travel history somewhere that we are going to find out about more? So it's hard to say right now how widespread it is because we don't even know exactly what it is. So we're still in the investigation stages, basically.
Follow up, and this is the last question.
Okay, thank you, Doctor, for clarifying that. I'm also wondering, with these new variants of concern that are, half as much more contagious, what is that going to mean for vaccinations and getting to a state of herd immunity? Do we have to get more people vaccinated to get herd immunity when you have variants that are far more contagious?
Well, the fact that it's more contagious, the experience, or at least what the modelers have told us, is that the doubling time for cases will be much lower. So cases will be spreading more quickly. So to get herd immunity, my understanding is with a non-variant strain, we're looking at 60 to 70% coverage of the population. And I've understood that we may need more like 70 to 80% with a variant strain. We would need more herd immunity, more population coverage to achieve herd immunity.
Thanks, everyone.